Okay guys, this is video number 3 for alterations to pulmonary function. So we are going to go through now obstructive lung issues. So if it's obstructive, that means there's something in the way. Okay, so first one, asthma. Okay, so asthma is a chronic condition. It's a chronic inflammatory disease. In this case, the area that's chronically inflamed is the bronchioles. Okay, so you have chronic inflammation of the bronchial wall. So if we think about, here's a bronchial, right? Here's the lumen. Here's the wall. If the wall becomes inflamed, right, and swollen, then you're going to have a lumen volume, I'm exaggerating, that's much smaller, okay? So this is going to be normal lumen volume. In the throes of an asthma attack, that's going to be your new lumen volume, which is much smaller. It's going to obviously be very obstructive to having airflow reach the alveoli. Some of the risk factors associated with asthma would be things like age, exposure to allergens, living in an urban setting. It's thought that pollution can contribute to asthma. There's been many studies done in places like the Bronx where they've looked at air quality and kind of correlated it to emergency room visits for asthmatic attacks. Reoccurrent viral infections. Obesity, because you're in a pro-inflammatory state. For certain people, if they inhale certain irritants or particulate matter, that can trigger an asthma attack. But one of the things that they think has shifted the way our immune system responds is that we've had a significant decrease in the exposure of our bodies and our immune systems to infectious organisms. That's called the hygiene hypothesis. Essentially, we're too clean, okay? So if we think about that, many, many years ago, young kids played outside, they played in the dirt. We didn't have Clorox wipes to be wiping down every surface. We didn't have hand sanitizer to take all the bacteria off our hands. And so people ingested things that kind of strengthened, for lack of a better word, their immunity. Now it's thought that because children, in particular very young children, grow up in such clean, hygienic environments that their immune system doesn't see some of those things to mount an appropriate response. So when it sees something that's potentially bacteria or something harmful, it has this very hypersensitivity to that particular item, and now it can trigger things like asthma. It's a thought, not fact, a thought. So some of the signs and symptoms when someone is having an asthma attack. So I want to clarify that asthma can be fatal. I think most people, because they manage their asthma, think that it cannot cause death, but it absolutely can. So let's talk about why that's the case in a second. So when someone has asthma, some of the symptoms, some of the signs and symptoms you would see: coughing, wheezing, difficulty breathing, some people can have increased mucus production in their airway. That can, as a late stage of significant damage connected to asthma, would be something like you'd have mucus plugs in the airway, which would be something that, if left untreated, is absolutely going to be obstructive for airflow. There can also be damage to the wall that's permanent, damage to the wall of the bronchiole in asthmatic patients. So coughing, wheezing, difficulty breathing, increased mucus production, bronchospasms, and prolonged expiration. So how do we treat asthma? Okay, so the treatment of asthma, I would say, probably has a 3-pronged fork. Okay, so there's three things that I would say we want to kind of discuss when we talk about treatment for asthma. Many people who are asthmatics have what are called asthmatic triggers that will trigger an acute attack. So they're kind of in this chronic inflammatory state. But in the presence of certain items, they then would have an acute attack where you have significant tightening of the chest and true difficulty breathing. So we want to identify and then avoid, where possible, triggers. Okay, if your triggers are the smell of burning candles, don't burn them anymore. If your triggers are things like perfumes, detergents, you want to cut those out of your house, right? Don't wear perfume. Use detergent that's not quite so scented. Okay, if your trigger is dust mites, perhaps you need a vacuuming system with a better filtration to maybe kind of clear some of that out of the air. The problem with this is it's work to identify and then avoid your triggers, and a lot of people don't completely identify all of their triggers and then can't avoid them because they don't know what they are. Now, in some cases, I can use my dad as an example. He's got many, many, many triggers that it would be all but impossible for him to avoid all of his triggers. But what you want to do is kind of reduce your exposure to your triggers, and so that you're not having to continually then use an inhaler, a rescue inhaler, in the event of acute attack. Okay, next level treatment would be something like a beta agonist. This would be more for rescue. Albuterol. This is, as we know, a good bronchodilator. That's going to open our airways. And we kind of talked about albuterol when we talked about allergies, when we talked about anaphylaxis. But this would be another level treatment for an individual who is asthmatic. They would carry this as their rescue inhaler. And then we want to kind of get at the ahead of the inflammation. So maybe a different type of anti-inflammatory agent as kind of your maintenance drug, your long-term treatment, or something like Singulair, which again we discussed when we talked about inflammation, as a leukotriene antagonist. So this is approaching the anti-inflammatory piece in a different angle. For some people, the old school anti-inflammatory was corticosteroids that they would inhale. Now, the problem with taking a long-term corticosteroid treatment, as you all know, is then the corticosteroids themselves have pretty significant side effects. Another treatment is monoclonal antibodies to IgE. IgE, as we know, are the class of immunoglobulins that are connected with the release of histamine. Okay. The next obstructive pulmonary issue that we want to talk about is our big umbrella of COPD. Okay, so this is chronic obstructive pulmonary diseases. Okay, this is a chronic condition whereby you have some sort of permanent obstruction that is prohibiting proper flow of air to the alveoli. So this is kind of a big umbrella, and then there are things that are classified as COPDs. This is the leading cause of chronic lung disease in the world, and is the fourth leading cause of death in the United States. So some risks, old school risks for developing a COPD would be someone who was a former smoker, some environmental exposure, and then indoor and outdoor air pollution. I cannot emphasize this enough. Okay, we're very aware, if you live anywhere near New York City, of outdoor air pollution. I would argue that in some spaces, indoor air pollution is as much a problem as outdoor air pollution. You know, now people like to own those plug-in things and candles and the things from Bath and Body Works, and they've got perfume and detergent and all of these smells. in their homes that are essentially hermetically sealed. No one wants to open the windows and ventilate their home very often. So that can create an environment where you have a lot of chemicals built up in the air that I would argue in some cases is fairly toxic. And so someone who has COPD would want to reduce their level of indoor air pollution as well. And it's a big risk for people who have COPD as well, but for developing a COPD, okay? Different types of COPD. You would have things like chronic bronchitis, is an example of a COPD, as is emphysema. When someone has chronic bronchitis, so you can have acute or seasonal bronchitis. It means you have an acute inflammation of the bronchi, okay? Along with that, you have an excessive amount of mucus production. When it's chronic, it means you have it for longer periods of time, so greater than 3 to 4 months of the year. What this gives us is you have chronic bronchial inflammation and an excessive amount of mucus production. Both of those are going to obstruct the airway. Again, if the bronchial wall is inflamed, then it's going to kind of shrink that lumen diameter and less air will be able to flow through. With increase in mucus production, you're going to have mucus in the place where air should be. And so that's certainly going to hinder the ability for air to flow in and flow out. In addition, wherever you have mucus, there is the capability that you could develop infection. And so people who have chronic bronchitis are at risk for recurrent pulmonary infections as well. Okay, treatment. And this is going to be the treatment you'll see for some things connected to emphysema as well. Would be bronchodilators, which you can kind of imagine, again, something is going to open up the airway, get those muscles to relax so we can increase flow. Mucolytic drugs. Like Mucinex that you would get over the counter. Lytic, right? Remember, to lyse means to break. Muco is referring to mucus. So something that's going to break down and thin the mucus, that when an individual would cough, it would make it easier for you to expel mucus and get it out of your airway. Okay? Again, anti-inflammatories. These are really aimed at reducing the inflammation in the first place. And again, if we can reduce that inflammation just a little bit and thin the mucus, it's just going to make the exchange of air through the airway, through the bronchi to the alveoli just better. We're trying to enhance it in as many ways possible. If it's become something infectious, you could give antibiotics, of course, depending on what the root cause of the chronic bronchitis is, or if someone develops a secondary pulmonary infection. And then, of course, oxygen, giving supplemental oxygen to your patient. Okay. The second type of COPD is emphysema. Okay. When someone has emphysema, they have a permanent enlargement of the alveolar wall, and sometimes the alveolar wall becomes a bit deteriorated. So you get, a loss of elastic recoil, and you can get kind of air trapping within the alveoli, and that's what's going to contribute, especially if the alveolar wall becomes a bit enlarged. That air trapping can contribute to the presence of blebs, which can then rupture, and then that can cause issues, again, with disruption of gases, pressure in the pleural space. You have the one with the little 0 for primary emphysema and secondary emphysema. Primary emphysema is a genetic condition. Secondary emphysema is the one that's more popular, right, and is associated with smoking. Okay, so the genetic disorder is an alpha-1 antitrypsin deficiency. What happens is when people have primary emphysema, the breakdown of the protein elastin occurs very rapidly in an unchecked fashion. So if you have a decrease in the amount of elastin, you lose some of that elastic recoil, of course. Okay. Secondary emphysema is the one that people are more familiar with. That's related to smoking, secondhand smoke, that includes smoking marijuana, vaping. I don't know yet. There hasn't been an really excessive amount of long-term studies that looks at the impact of vaping on the lungs, but early data would show and support that vaping's not good. Okay, so I don't know if vaping eventually could lead downstream to emphysema. I think that's TBD, but certainly the early data that's coming out is saying that vaping is certainly not good for healthy lung tissue. Okay. Obviously, people who have emphysema are going to have difficulty with expiration, right? Exhaling of air from their lungs. So, some of the issues, I'm not even going to call them symptoms, because this is a long-term condition. Okay, so if you have a drop-off in recoil, then you can't expel CO2, and if you can't expel CO2, it's going to rise in your bloodstream, and that is going to drop off the pH and will contribute to acidosis. So you first would have hypercapnia, and that would contribute to a drop off in pH that would lead to acidosis. You would have air trapping if you had that, the expansion of those alveolar walls, which can lead to blebs. That can then rupture and significantly damage then the space between the alveolar wall and the pleural. Okay, you can also have increase in blood pressure in the pulmonary artery. And I believe that COPD's emphysema being included are the number one reason that people have PAH, which is pulmonary artery hypertension. This is dangerous. If you have high blood pressure in the pulmonary artery, remember pulmonary pressure is lower than systemic pressure. So if blood pressure is elevated in the pulmonary artery, it can cause significant damage to those alveolar capillaries, which is going to put you really in acute respiratory distress. Okay, the treatment for emphysema depends on the severity of the case, but would include things like, at the end game, supplemental oxygen and ventilation. Okay, but most people you see with emphysema are getting O2. They're getting supplemental oxygen. Okay, I'm going to stop there, and then we'll do our next set of videos on respiratory tract infections.